Hi everyone, welcome to today's Strategy Unit Neighbourhood Insights session. Today the topic is whether do with is the essence of neighbourhood health. I'm Fraser Batty, I'm the Head of Policy at the Strategy Unit, and I'm going to be chairing today's session, which features Connie Youngans-Minton from Imperial and Adam Lent from the King's Fund. This session is the third in the Neighbourhood Insights series. In the first session, myself and Justine Wiltshire from the Strategy Unit looked at the history of the desire to shift care from hospital to community, and also some of the analytical work we've done around the likely future of that ambition. In the second session, we looked at the risks of risk stratification, and we did that with Stephen Wyatt from the Strategy Unit, with Jess Morley from Yale, and with Thea Stein from the Nuffield Trust. And we've got the recordings from those sessions on the Strategy Unit website if you'd like to go back and have a look at them. Just a few little bits of housekeeping before we get into the content of today's session. You may have noticed that you have had your cameras automatically turned off and you've been muted, not because we don't want to see you or hear from you, in fact, quite the opposite. We do really want to engage with you as part of this session, so please use the Q&A function that you can see within the screen. When you ask questions, you will also notice, as well as being able to ask your own question, you can upvote other people's. So please make use of that function. It will help me as chair get a sense of the questions that you want to put the way of Connie and Adam. Today's topic then is do with the essence of neighbourhood health. It's completely fascinating, the number of competing theories, in a sense, as to what neighbourhood health is about and how it is supposed to operate, and how by working in a neighbourhood fashion we're supposed to be helping to bring about better outcomes for the communities that we serve. When at the Strategy Unit we've looked at the different areas working within the neighbourhood health programme, and when we've looked at their logic models, we can see the importance of relationship expressed all the way through what they're attempting to do. And that means relationship in many different ways. It means relationships between organisations in an area. It means relationships between different members of staff. But also there's a very strong emphasis on relationships with citizens. And in expressing that, the sites seem to be saying they want to do something different in the relationship that services might have with citizens. In some senses, this is quite well-trodden ground in the NHS. There's been a sort of fairly long-standing interest in things like shared decision-making, but I don't think many of us would think that that has actually cashed out in a widespread way in reality. And I think it would be reasonable to say that particularly the NHS remains a service that does to people in to a degree that many of us wish wasn't the case. So does neighbourhood health give us an opportunity to change that? Does having a more localised way of arranging services give us an opportunity to reshape the relationship with citizens in some fundamental and important sort of way? And what does that say about the delivery of public services and civic services in the round, not just the NHS? So to explore that topic, we've got Adam Lent from the King's Fund and Connie Youngans-Smith from Imperial. I'll just introduce them very, very briefly. Adam specialises in leadership and organisational development at the King's Fund. And before that, he was chief executive at New Local, which has been very active in this sort of territory. He has articulated an approach to doing with, which is where I've taken the title from the session from, both for neighbourhood health, but also for public service reform more generally. So I'm going to ask Adam in a moment to just outline what he means by do with, just give us 15 or 20 minutes on that. And then Connie combines clinical work as a GP with life as an epidemiologist at Westminster City Council, with academic life at Imperial College, with the ambition and now the actual development of the community health and wellbeing worker model, which she's brought over from, or helped to bring over from, Brazil, and she'll tell us more about that. So the way we'll run the session, I'll ask Adam to speak first for 15 or 20 minutes, and then Connie for the same, and then I'll bring them both together for question and answer at the end. So that's the way we'll run things. So I'd like to invite Adam, first of all, to give his perspectives on the topic.
Thank you very much, Fraser. Hello, everyone. I was lucky enough to be in Wigan last week, where I was doing some work on neighbourhood health, and I visited this amazing place, which is Wigan and Lee Hospice, which is a truly remarkable facility in Wigan. And the chief executive of the hospice, Joe Carby, who I was talking to about neighbourhood health, very much in line with what Fraser was saying, just said to me, neighbourhood health is about relationships. It's not about buildings. And this is coming from someone who actually runs a truly amazing building as a hospice in Wigan. But I think that comment, neighbourhood health is about relationships, not about buildings, sort of goes to the heart of two fundamentally different understandings of neighbourhood health. And I would argue two fundamentally different understandings of healthcare and public services more generally, and potentially you could argue two fundamentally different understandings of society, politics as a whole. The first of those, I think, sees neighbourhood health essentially sort of as a continuation of business as usual within the health service. So it sees neighbourhood health really as being based broadly around biomedical treatment-focused care. It's got a very strong emphasis on targets, focused on specific health conditions, and it's got this sort of obsession with productivity, which of course is, very dominant in healthcare thinking at the moment. I think the only real difference in this understanding between neighbourhood health and healthcare as it's currently run is pretty much just about location. The idea that somehow taking healthcare services out of hospitals, placing them in neighbourhoods, however you define that, in a neighbourhood health centre, a building, is going to make some sort of fundamental difference to the provision of healthcare and its impact across the country. And, as Fraser said, I have sort of characterised this approach broadly as a do-to approach that understands the role of healthcare and neighbourhood health as essentially being about doing things to people, not out of any particularly malign intent, just because that's the underlying understanding, the ontology, if you like, the way that we understand healthcare as something that experts, professionals do to people who don't have that expertise and that professional understanding to be able to look after themselves. I should say that this approach loves buildings and it loves the idea of neighbourhood health centres. This is the sort of core of what neighbourhood health should be about. Joe, the chief exec in Wigan, just said quite bluntly to me, the problem is people don't want to come to health centres. So you need to think about a fundamentally different way of reaching people if we really want to do neighbourhood health. The other approach, the alternative understanding, sees neighbourhood health as an opportunity or as a means to make that really serious shift to community-based healthcare that has a foundational focus on prevention and population health. It's a chance to make that shift away from the biomedical treatment-focused model to a model that is holistic, hyper-integrated care that, as anyone who's done any serious, deep prevention work knows, is the basis of preventative population health. And it gives communities the resource, the power, and the responsibility to care for their own health and well-being, rather than having to rely largely on healthcare professionals and the wider public sector. And again, given the title of this session, I don't need to labour the point, but for me, this is best described as a do-with approach that understands that healthcare has most impact, and preventative healthcare in particular has most impact when it is done with individuals, families, and communities rather than done to them. So, neighbourhood health, I think, is just one area where the tension between these two approaches, this battle, if you like, for the soul of what healthcare and health should be in the country, is being played out. There's a much wider battle, I think, going on about the NHS, about public services, and maybe about society in general, between these two visions, this sort of do-to, top-down, productivist vision, and this sort of do-with, human, relational vision of how we should work. And, I don't want to claim that the government is only focused on a do-to approach, because this is a real tension that is playing out as much in Westminster and Whitehall as it is in the rest of the country. And I think it's probably fair to say that there has been quite a significant fight over what is the nature of neighbourhood health. But look, we've got to be honest. One of these approaches, out of the sort of do-to and the do-with approach, one of these approaches is massively incentivized, massively enforced, and encouraged over the other. Money, organizational culture, and the targets that are imposed from above all favor that do-to biomedical top-down type approach. So, I speak to very senior people in ICBs, in trusts in particular, who recognize the need for a shift to a fundamentally different way of working and see neighbourhood health as an opportunity to do that. But to be frank, it's almost impossible for them to make the shift. The whole way the system is set up incentivizes them very, very strongly to continue with a do-to way of working. And then we've got to think about the fact that also everyone working in the health service at the moment is enormously pressurized. There's very, very little time to do anything other than firefight or deal with the day-to-day caseload. There's enormous amounts of burnout, morale is low. There literally is practically no space or no time or no bandwidth for people in the health service to think differently about how they might do things, let alone actually make that transformation happen. So what that means is that I think inevitably neighbourhood health has fallen into, almost by default, into a sort of do-to way, or the government's view, put it that way, the government's view of neighbourhood health has fallen in line with a sort of do-to way of doing things. And if you look at the neighbourhood health guidance, which came out, 2 or 3 weeks ago, something like that, it's sort of amusing because when you read it early on, it says neighbourhood health has to be a balance between nationally set targets and locally set targets. So it seems to be sort of opening up the space for a more do-with approach. It's sort of saying, yeah, we need national targets, but the community, the neighbourhood also needs to have its say over how healthcare is delivered and how it's designed. But the sort of more you look into that document, the more you realise it's not actually the case. So when you look at the section about how you're going to set local targets, the guidance points you to what's called something called the local outcomes framework. And when you look at the local outcomes framework, you discover that what they actually are is just another bunch of nationally set targets. So, really the do with aspect of neighbourhood health is being played down. And, there's another section in the guidance where, again, they talk about the need for locally set priorities, community set priorities. And then they have this, what I think is a brilliant sentence, says, nevertheless, there are many common sense actions that work well everywhere. And then it goes on to list these so-called common sense actions. And these are things like improving the productivity of GP practices, getting integrated neighbourhood teams to focus on conditions like cancer, coming up with alternatives to hospital. These don't sound like common sense actions to me. They just sound like the sorts of things that government always talks about and wants done. And to tell the truth, I don't really accept the premise of the statement. I'm not sure there are actually any common sense actions that work well everywhere. I don't think that's the case. The only place, in my view, that has really made that sort of systemic shift to a genuinely do with neighbourhood health type approach. And there are plenty of places across the country that are doing great initiatives and innovations around neighbourhood health, and Connie's going to outline, one of the best. But the interesting thing about the place I'm talking about, which is Fleetwood in northwest England, and apologies to others who've heard me speak about this before, because I do speak about it a lot. Fleetwood is different because I think it's the one place that has really managed to shift systemically to a fundamentally different way of working. Fleetwood, for those who don't know, is a pretty poor town of around about 30,000 people just north of Blackpool. But what they've done there, led by the primary care network, is created a deeply integrated, holistic approach to primary health care that is, most importantly, always community-led. Everything that is done around primary health care in Fleetwood is decided and led by the community, not by institutions, not by the primary care network, not by the ICB, but by what the community wants to do. And as well as creating a much more human, relational, mobilized community that is really taking action to look after its own health and well-being, they've also done all the things that we're told absolutely need to be done. So they've cut A&E admissions, they've cut CAMS referrals, they've even massively cut the incidence of antisocial behaviour in Fleetwood. Now, they do have a building. They have recently opened a community health and wellbeing hub. It's actually what was the old hospital, community hospital, which was closed down by the NHS some years ago. But the really important thing about that building is it didn't come out of nowhere. In fact, the building, this new community health hospital hub, didn't actually open fully until last year. But the mobilization of communities, the conversations that led to this fundamentally different way of working, or what some people in Fleetwood describe as a fundamentally different way of being, that began all the way back in 2015. So it's been a decade of trust building, relationship building, mobilization within the community before they got to the stage of actually opening a building. And that building is now absolutely flying and is, a remarkable place to visit and see what neighbourhood health can look like. But as I said, it didn't emerge out of a vacuum. It emerged out of those relationships that they spent a decade building. So where does that leave the wider system? And sort of my final point. I don't think the system is going to shift towards a do-with approach to healthcare generally or to neighbourhood health until we have a fundamentally different discourse and debate within Westminster and Whitehall in the sort of highest echelons of those who run the NHS and the wider public sector. We need a government to come to power that I think is willing to be honest with the public about the failures of a do-to approach and to face down the media and to push on with change when they do things that inevitably people are going to scream about, particularly opposition parties and oppositional media. So, for example, things like getting rid of these ridiculous top-down targets, which only drive perverse behaviours, behaviours that actually are damaging to people's health. That sort of thing needs to be ditched, but clearly there's going to be huge opposition to that, and we need a government willing to face that down. I'm afraid without that, we're sort of stuck in a failing, what you might call a sort of failing chain of accountability, where trusts and PCNs are answerable to ICBs are answerable to NHS England, Department of Health, and NHS England, Department of Health are answerable to the Secretary of State, and the Secretary of State is answerable to the media and voters, who unfortunately are profoundly misinformed and misled about what good healthcare looks like. So we just keep maintaining this focus on targets due to turning the screws harder and harder and harder on everyone below them in the accountability chain to work harder, to drive more and more people through the system as quickly as possible, not aware that as you drive people more quickly through the system, that means they don't get better, other conditions aren't dealt with, their broader holistic concerns are not addressed, and they just stay ill, or they get iller and they bounce back into the system and back on to a waiting list. The only alternative I see to waiting for that moment of revelation and enlightenment in Westminster and Whitehall, which I'm not holding my breath for, is for us as people working in communities, in the public sector, drawing on public services, to come together and start making the change now, whether we are given permission to or not, in the way that somewhere like Fleetwood has, which is basically to say, we're not going to listen or respond to all the noise from above. We're just going to get on with doing the right thing here and now for our communities and for their health. I'll stop there. Thanks a lot, Fraser.
That's excellent. Thank you very much, Adam. I like the way you set it up, the sort of do to and do with competing camps, and as you put it, the battle for the soul of the neighbourhood, the battle for the soul of the way that we would think about those things. And then I like the way you end as well, both seeing the need for, as it were, change at the top, but then also seeing the opportunity for us to just get going with doing things differently tomorrow, not necessarily requiring maybe desirable change at the top, but not necessarily requiring it in order for action to be taken. So I like that invitation as well. Connie, can I bring you in now? You're going to give us, in some respects, a very good practical exemplification of some of the principles that Adam has been pointing to. So let me hand over to you. If you have 15, 20 minutes presenting, and then I'll draw you both back in for Q&A.
Thank you, Fraser. I'm not as good as Adam. I need my props, so I've got some slides for people. Not sure you can see them. I can't see anybody else, and the light might
they've been shared.
So without further ado, I'm going to talk about the community health and wellbeing workers doing with in practice. For those of you not familiar with the model, this was brought over from Brazil by Dr. Matt Harris, actually, who is a clinical reader at Imperial College London. And he worked as a GP in Brazil in the early 90s and worked with a team of community health workers. This model has now scaled over the last 30 years to about 400,000 workers and near whole population coverage. And I'm going to share with Fraser some of the evidence that is clearly linked to the community health worker work that has seen remarkable improvements in population health. Dr. Harris distilled the model into 4 principles, conveniently called the CHEWI principles, and all 4 of those have to be in place for this model to be the model. C for comprehensive, so from baby to grandmother and everyone in between, everything is in scope that is of concern to the household. And H for hyperlocal, so 120 households are each regularly visited by people from that community. U for universal, so everybody is worth knowing, everybody is reached. No referrals required, no need to present with anything, but obviously some people need more attention than others, so the universal is proportionate to the need at the time, which is fluid. And I for integrated, so they're part of the primary care team, bridging communities and systems. So how do they contribute to this neighbourhood idea? Community health workers are empowering themselves, and I don't like this word empowering particularly, but I haven't found a better one. So post it in the chat if you have any suggestions. But they empower themselves and their communities concentrically. So you can see on the left-hand side how they put the hood back into neighbourhood. There's a picture of the neighbourhood from the Brazilian community health workers, and each colour represents a territory geography. And on the right-hand side, Churchill Gardens, each colour represents a community health worker covering the building that they look after. And apart from having these proactive home visits, they also have really important community development functions. So they run coffee mornings, lunch and learn events, that's sometimes themed. So here's an example of the dementia coffee morning. And the core of what they do is deep listening, and that is really, really important. And their response is versatile, so it could be advocating, navigating, educating, connecting. It's collaborative delivery, so they have to do this with the appropriate professionals and other people. They can't be everything for everyone and do everything. So their superpower really is building relationships. So they have three jobs. They build relationships with their households, they build relationships with the professionals in their locality, and then they build relationships among the people in their locality to tessellate the community, really. And so they're recruited on character, not characteristics. And most of our community health workers didn't have a job before they started working in this role. They were recruited from the community champions pool, so they knew their community really well and were volunteering. So here are my two teams from the south and the north, and in the middle, I'm not going to read this out, but the many things that they do, this is not exhaustive, but promoting lifestyle changes, spotting red flags, supporting people with chronic disease, bringing professionals in, educational talks in local schools, and so on. The Community Impact Coalition has distilled what community health workers globally actually need to be doing their job really well is those 4 S's. They need to be salaried, they can't be volunteers. They need to be supervised and supported, more importantly. They need to be skilled and they need to be supplied. They need to have the resources to do their job. And I meet with my teams once a week to discuss cases or do bite-sized teaching. They are supporting each other. They're very reflective in their role, and they learn and have training as is required. So Fleur de Meyer, who's a street doctor in Holland, calls this precision community medicines model, and I really love this term because it kind of really is what it is. It starts with the household and the needs of the household in a very precise and tailored way, building trust with that household, and then thinking with the residents about what and whom they need. So they connecting them to the system, bringing in professionals as needed. For example, a health visitor, a neighbour, the grandmother, the community matron, or the GP, whoever's appropriate and available. So it's also immediate. And then they go to professionals and services as needed, so providing advocacy and allyship. They translate, they do a lot of hand-holding, and what's transpired in the last 4 years that I've worked with this model is that signposting is often really not enough. And I sometimes wonder whether it's actually a waste of money doing that and how much we're wasting with that. It's kind of like either do it properly or not at all. I don't know. Being present, providing continuity and care. So the Brazilian GPs call the community health workers their legs and arms. I call them eyes and ears, but they are providing that continuity that we're not really able to provide anymore in GP. They do care navigation, education, social prescribing, coaching, and so much more as is required by the household. So there's no exclusions, no eligibility criteria. Here's a 6 months engagement snapshot from the team in the north, and it's just to highlight sort of how long it takes. So we've got 11 CHUIs, as they call themselves, in the north, conducted 1,528 visits, and on average in those 6 months, each community health workers conducted 139 home visits. And if you're good at maths, you'll kind of spot that this is not 120 visits a month. And this is because this is a real journey. So building trust in the community is really hard work, particularly in those communities where people have been let down by the system in so many ways and are really not willing to engage easily. So this was as of December last year, we'd reached about 55% of the households. This is now around 60 and growing. But the really good news is that once people are engaged, they don't tend to disengage. And you can see here that over time, the repeat visits are growing, and there is sustained engagement with households. And our CHUIs actually say that the job gets easier as the relationships bed in. So bear with me here, but I think a good comparison of the community is with the microbiome, like a societal substrate. And why am I talking about that? So a healthy gut microbiome is characterized by comfortable, regular digestion, high energy levels, strong immunity, clear skin. Indicators include high microbial diversity, quick recovery from illness, while dysbiosis, which is the opposite of a healthy microbiome, is an imbalance in microbial communities, digestive issues, bloating, constipation, diarrhea, anxiety and depression, etc. And a community you can think of in the same way. So a healthy community is characterized by safe, accessible environments, strong social cohesion, equitable access to resources. Key indicators include high trust, active civic participation, diverse employment, and robust infrastructure that supports mental and physical well-being. While the opposite of that, a depleted community or an unhealthy community, is characterized by high levels of social isolation, lack of trust, fear of speaking openly. Key signs include high crime, discrimination, lack of resources, fragmented, indifferent communities. And why am I bringing this up? And what's the relationship with health and social care? Well, and I've seen in the chat somebody said, we need to distinguish between healthcare, neighborhood healthcare and neighborhood health. But actually, the two are so intimately connected. So irritable bowel syndrome, interestingly, and related gut dysbiosis cost a massive amount to the NHS, ranging to up to 2 billion annually. And equally, this research from the Eden Project shows that disconnected communities, depleted communities, estimated to cost the British economy over 32 billion annually, and the NHS demand is around 5.2 billion. So how can we fix the community and make it a healthy community microbiome? Are the community health workers the probiotics? And as is true for probiotics, one Actimel won't do. You need lots of them. So how do they do that? I'm not going to read through this because of time, but just to highlight a few things, they're asset-based and resident-led. So they don't just think like me as a GP in services, they think about the community much more sophisticated. So if somebody needs a chair and somebody's getting rid of a chair, there's your chair. So because everybody is worth knowing in the community and they spend time with people who don't just have a problem or a need, they also know what the resources are in the community and the assets. They don't really care about these fault lines between organizations that we have. So they don't really mind if somebody works for the local authority or the NHS, as long as they can do something that they need for a resident. And so it's really important that the system starts wrapping around them. And I'm going to talk about the Octopus Integrated Neighbourhood team in Westminster. So this is it. This was the octopus in the zoo that we had last year. The octopus is, the idea is that you have somebody, a creature, if you like, with 8 tentacles. That's our frontline roles. An octopus has 3 hearts: the NHS, the local authority, and the community sector, and that the tentacles think independently of the octopus. So they have agency, belonging, and control. And the octopus came about because uh, one of our clinical directors, Dr. Sal Kaufman, was very impressed with how the community health workers are actually bringing in relationships, building relationships with other frontline roles like the community matrons, the health visitors, the GPs, and intelligently bring them in for their residents. So he said we all need to work like this, and this is what Adam was talking about with the Fleetwood Health, that really the whole system wraps around it. What's interesting is that it didn't really take new services. It didn't take a restructuring from above. It actually happened because of the community health worker and their way of working. So I would argue that if you pivot to a more relational way of working, services change as a result automatically. And I'd like to see them as part of an ecosystem. So it's not the often they're pitched against, like, should we have social prescribers or community health workers, or should we have health coaches or health trainers? That's not really the question. The question is, how are they deployed and how do they work well with the ecosystem? So they encourage volunteering in the community as community health workers, and volunteers also see that there might be a paid role at the end of it. So it's really helpful if we think about anchor institutions. So what does it need to flourish? It needs stability. We talked about this. I like to say that we've got more pilots than British Airways in the NHS, and this is not really good. This commissioning model that we have, where everything falls over after 12 months and we start from scratch. And you've seen that the WHO puts the implementation of a neighbourhood model at 5 to 6 years, and it's taken us 2 years to get to 60% of the population. This needs time to bed in. It needs to have space to allow for failure and learning. Kate Shields from Cornwall calls it putting a cloche over it, protecting it to grow and strengthen. We need an economy of scale for systems change. Don't deviate from the TUI principles, otherwise it's just more of the same. And prioritize relationship and trust over tasks and transactions to protect integrity. So I've left the outputs and outcomes to the end, because to me this is a to-do metric. Of course you need it. It's a kind of like price of admission, I guess. But we know from Brazil that this works. We don't need more evidence, but we have the evidence here that it works in the UK. What we need now is to make it work. And just to end that, the community health worker model can also be a to-do model if it's deployed in the wrong way. So it can be task mules or street level bureaucrats. And that's the opposite of what Adam, I guess, was talking about earlier. So I'm going to stop here and I'm going to share my slides with Fraser and also some resources.
That's excellent. Thank you, Connie. Thank you for running us through that. I think what I really like in your presentation is it's both a really nice sort of practical exemplification of many of the principles that we've talked about, and then also you can sort of point to some of the wider factors that will help this kind of thing to work, or in fact might see it being perverted. I've never seen you talk about it in quite that way before, that you could actually implement this model in a very do-to kind of fashion. That's really interesting. Can I bring Adam in as well, so that I've got the both of you to ask questions with. I've been diligently keeping an eye on the Q&A function and looking at the ones that have been the most upvoted and so on. There's quite a strand of questions about the topic of relationship, as you might imagine, and it's kind of an interesting topic, and it's an interesting set of questions in a way, because it's kind of hard to express, and it sort of comes out quite clumsily. So I think I'm apologizing for asking you guys quite a broad and perhaps clumsily put question. I think I'd characterize it as how how come we overlook the value of relationship so much when we're talking about public services and when we're talking about the NHS? Connie, you said something like we should prioritise relationship and trust over outputs and activity. And I thought, yes, and I know what is the easiest to measure and the easiest to count and what gets the most attention in that. It's outputs and activity. So we've got something that's really important that we know matters, relationships, relational quality. And yet all of our measurements and all of our efforts are on the things that, in a sense, you're trying to draw our attention away from. Someone in the questions asks, well, okay, should we then be attempting to measure relational quality? Is that the route that we should take? So I just want to invite both of you to sort of have a go at this topic of relations and relational quality. And then perhaps this question of, okay, well, should we go down the route of trying to measure that more and abandon, activities and outputs in a sense? Maybe, Adam, if I give it you first, because you've been having some time to think and rest whilst Connie's been talking.
Yeah, I mean, we know it when we see it, really. I mean, if you go up to Fleetwood and you stay in Fleetwood for a day and see all the stuff they're doing, as a human being, you can just see this is an approach that is built on trusting, caring, compassionate human relationships. And it's sort of fundamentally different from a system that treats people as conditions or units of cost or sort of things to be processed as quickly as possible. I just want to be clear here, because I'm being very critical of that model, that the NHS or the public sector does an enormous amount of good. We wouldn't want to be without it, of course we wouldn't. But the frustration is that it could be so much better, and it could be doing so much more on prevention, stopping people getting ill in the first place or getting into personal crisis in the first place. That's my beef, if you like. And we overlook that in large part, I think, because these institutions that are at the heart of public service delivery, they're relatively new creations. They're these giant bureaucratic bodies that have really been created over the last 150, 200 years, and they were designed to do beneficial things. But let's be honest, they were also designed to advance the careers of the people who set them up, to create professional specialisms, to put certain people in charge, to direct resources to the new powerful professional classes that were beginning to gain influence and power in the 19th century. So, the institutional setting itself is a difficult place to really build in deep, trusting, sort of relational type approach, which is why, and I think someone put this in the chat, we almost need to do this sort of stuff outside of the institution. It needs to be done in the community. And that's sort of what I think they've done very well in Fleetwood. In terms of measuring, well, I think you can measure this stuff just in the same way as you measure everything else. And it is being measured in that way. If you look at things like community appointment days down in Sussex, or community-led support, which is an approach to social care across the UK, you can look at the hard metrics, so-called hard metrics. They're cutting waiting times, they're saving money, they're reducing waiting lists. But then you look at things like staff experience, and staff overwhelmingly report that when they move to this sort of more relational do-with way of working, they say the phrase I hear, this is what I came into public service to do this sort of work, not just process people as quickly as possible. You can look at patient experience, you can look at patient behaviour change. Indeed, a project I'm working on in this space in Sussex is doing exactly that. And you can look at lived experience. You can talk to people about their experience of being given healthcare in a different way, and you can go and see it for yourself. I would say going to places like Fleetwood, going to a community appointment day, going to a community-led support hub, working with CHUIs, you see a fundamentally different way of being. But the final thing I say is, don't fool yourself. You can measure it to within an inch of its life. It's still not a guarantee that it's going to persuade people to do things differently at senior levels. I've seen, everyone at the senior level says, show me the data, show me the evidence. And you show them the data and you show them the evidence, and they still don't change the way that things are done, because status quo bias is so strong. People irrationally stick with the way of doing things because it's the status quo and it's what they feel comfortable with, and there's all sort of other incentives inevitably built into that. So data, measurement, evidence, absolutely. But the real way alongside that will change people is through pressure, just demanding the change and getting on and doing it with ourselves. So they're either on the bandwagon or they're not, basically.
Thank you. Connie, is that a smile of recognition? I can see
violently agreeing with Adam.
maybe take it on this. So this question of relationship at the core of things, but then also this point about, okay, the extent to which measurement and evidence and data actually does win the day. I'd be interested in your reflections on that.
Yeah, so the things that come to mind, apart from everything that Adam said, is that it's probably, to me, more of a culture. So I understand why the NHS feels that they need to measure everything, because we're accountable, we're a public service. You want to know that you get good value for money. But like Adam says, I've seen that evidence doesn't, and we know that evidence doesn't get used in the way that it's supposed to, or that you expect it to. I think there is a lot of homeostatic defense. We have a kind of paternalistic, almost sort of Calvinistic approach to healthcare. We you can see what we value, so we don't have any space to connect anymore. So after the pandemic, the one thing that sort of got dropped in practices was probably practice meetings. so it's kind of like you can see more patients in that time. So it's become much more transactional and sort of efficiency of processes, and we're kind of a little bit stuck in this almost transactional hell now, and very fragmented. And I would say at the bottom of that is also trust. So we don't trust our GPs, we don't trust our patients, we don't trust our colleagues in other institutions, and I think that is a really important thing to pay attention to. So I would say creating the space for people to connect, making that a priority. I agree with Adam that you can measure trust, you can measure the quality of relationships. It's just that we're not doing it because that's not important to us. We measure bed days because that's what we value. So it's and I think we just have to kind of start doing it like we did in Westminster. We didn't particularly have a lot of senior buy-in. We started with a little pilot, and then we had some enthusiastic clinical director who really got it. And I think there is no shortage of evidence on this approach. We know from Compassionate Communities Frome that they halved their A&E admissions. We know from Bromley Bobo Centre that social prescribing absolutely works. We just know we've got 30 years of really solid evidence from Brazil, and people are people.
It's interesting, and someone says in the chat, and many of us will have seen, the Health Foundation have done a piece of work, I think they put out over the weekend, about declines in healthy life expectancy. So there must also presumably be some pressure from a sense in which the outcome that we would all presumably say that we care about appears to be going the wrong way. So that must also therefore create some pressure for doing something differently. Yeah. There's a good set of questions, a good set of themes in the Q&A box, which in a sense are about the practicalities of getting this stuff going. So Connie, you've just touched on it there, so maybe I'll ask you to expand first of all. We're in a system that both of you have described as being unideal. Connie, you just said we're stuck in a transactional hell. So we might observe that we're not in a system that is exactly encouraging of the kind of approach that you guys are pointing towards. Whilst we wait for the change of government and thinking that Adam is pointing to, what should we do in order to just start enacting things? What practical steps would both of you recommend to just start going in the right direction, in a sense? Maybe Connie first, and then Adam.
Yeah, so I think the way we started, we didn't particularly ask for permission or wait for a lot of evidence first, or try and work out the processes. We just got going, and I think what was stuck in my mind was that the first time Dr. Kaufman got a lot of frontline roles in the room in a basement in Westminster was about 15 people. Somebody said afterwards, who organized this? On what authority is this going ahead? Where does this fit? And I said, I don't know. Dr. Kaufman had an idea. we just tried to kind of make things better, and it was inspired by the way the community health workers work. So I think when you have a good idea, maybe sometimes we weigh too much on, we need to make this into a proposal, we need to get some funding for it, and then and often what happens is that a really good idea in the community gets funded for a year with transformational money, and then it's expected to be taken over. The money stops, the thing falls over, and that's the end of it. And I think building the relationships with people, a coalition of the willing, if you will, and finding a way to do it without necessarily all of the permissions or the money is maybe the way to do it, and get on with it in the community.
That's excellent. And I can see points in the Q&A about the role of the voluntary sector within all of that. And again, each of us would have observed a lot of sort of short-term contracting of community-based schemes done rather than longer-term relationship building and a sort of shared sense of shared endeavour between the NHS and the voluntary sector, perhaps. Adam, maybe have a go at the question of sort of like, where would you start and how would you get going?
Well, I sort of think about this at two different levels, so sort of locally and nationally. So how do you make the shift happen within, your own area? And this is going to sound horribly glib, really, but I think it's true. It starts with conversation. Every really impactful shift that I've seen, whether it's an innovation or a wider shift towards prevention, population health, relational, do with way of working, literally starts with conversation. It's people, clinicians, healthcare professionals, local government, whoever it is, getting out of their institutional setting, going out into the community and just starting a conversation about what matters to you. What do you want to see happen? Not with any sort of boundaries around it. We need to talk to you about type 2 diabetes and its very high incidence in your community, for example, starting in a sort of deficit-based way or predetermining what the conversation is about. But just going out and starting to have conversation, because through conversation, you find out what your community really wants, what they're able to do, what they're willing to do. But most important, you start building those trusting relationships. It all begins with conversation. That's just the beginning. But if you're not starting there, you're not really starting anywhere. So Fleetwood, community champions in West London, community appointment days in Sussex, a whole range of other things literally started with professionals getting out and starting to have conversations with people about what mattered to them and what changes they would like to see. At a national level, in terms of making a wider systemic shift, it comes down to that old sort of socialist principle, organize. The only way we're going to generate wider systemic change is by organizing, by making connections between the people who want change and creating a sort of grassroots movement for change. Because as I said, if we wait for Westminster to have their moment of enlightenment, we'll be waiting for centuries. We need to start building the pressure from below. The great thing about those sorts of grassroots movements is they put pressure on the more senior people to change the way they work. But more importantly, it gives people permission to get on with and do things differently, to basically say, we're not going to wait for the permission from the ICB or whoever it is, a bit in the way that you were saying, Connie. We just know this is good. We know this is going to work. It's the right thing to do. Let's just get on and do it. And if I can give a little plug to something, Fraser, if anyone is interested in being part of that sort of movement building, that organisation, there's actually an event on the 12th of June in Manchester that's bringing together people from across the country who want to try and get this sort of do with movement really underway. I don't know if I can put the link. Can I put something in the chat? Am I able to do that?
We can share it in the pack afterwards when we write out to people at the end. We'll definitely.
That was a shameless plug, but I thought there might be people on the call who are interested.
Can I plug away as well? So just because I was thinking it's interesting how fast the community health worker movement has kind of mushroomed across the country. It's really scalable, and within 4 years, from a pilot of 4 community health workers and 500 households to 28 sites across the country with 60 community health workers in Cornwall who have really kind of grasped it. They had a really visionary sort of ICB, really good relationships in place already, which made that possible. But the National Association of Primary Care has kind of like championed this model from the beginning and created a community of practice. So interestingly, in most of the 28 sites, it's kind of grassroots and not really connected to the ICB, although some are really organized and have good relationships and good vision to make that happen. But so joining a national community of practice to learn from each other. So we had the Chewies from Cornwall go to the Chewies in Westminster and vice versa to learn from each other. We're even doing it with Brazil now. So really it is kind of just getting going with the relationships and reaching out and supporting each other. There was also something that Adam said about the way we work, the relationship we have with the population. And I think it's the problem with institutions is that people are not hyper local. They often commute in from an hour and a half from somewhere else to work in a local institution and identify more with that institution, with the local authority or with the ICB than they identify with their local population. And I think you can measure how that changes with I think it was Dr. Debbie Gompertz, who runs a really innovative model, reaching out into the community with a multidisciplinary team. And she said everybody stopped talking about their own institution and started talking about their population. And I think that's where we want to get to, where people feel a belonging with that geography.
There's a suggestion for an innovative measure which might work at the board level and at the neighbourhood level as well. People talking as they identify with the institution, with the local area, with the local area and with the community rather than with the institution. Listen, I want to bring us to a close. We're out of time now. I want to do that by thanking both of you, first of all, for taking part and for offering your insights. I've really enjoyed it, and I imagine that everyone else has too. And we will share additional resources that you've got with people afterwards. So thank you ever so much, Adam, and thank you ever so much, Connie. That's very, very much appreciated. And then I just want to end with a plug of our own. I don't know if this quite counts as a plug, but the next session in the Neighbourhood Insights series is in a sense going to build upon the one today. We're going to be talking with James Plunkett, who's going to be helping us to draw in lessons for neighbourhood health from outside of the NHS, drawing on some good long tradition of neighbourhood working in other policy areas. And in particular, we're going to focus in on lessons from Big Local and the way that programme operated and the way it altered relations with between citizens and services. So thank you ever so much. Thanks again, Adam. Thanks again, Connie. Thanks again, everyone who attended. I hope you enjoyed it, and I hope to see you at the next session. Thank you.
Thank you.